What about community viral load? So I talked about the prevalence bathtub and the prevalent level of virus particles, and that's really what we mean by community viral load. It's an aggregate biomarker of a community's viral burden over a specific time period. How do we use it? We see it can, like a virometer, like a thermometer tells you how you're doing with your temperature, a virometer can tell you how infectious a particular community is and the transmission probability. We can use it to measure the effectiveness of combination HIV treatment interventions, and we can consider it as an upstream, temporally upstream marker for HIV incidence. Because if viral load is directly related to transmission, if it goes up in a place, you might see more cases there, so you might want to concentrate some resources in that geographic area or among that group of people. So these are some old numbers that many of you have seen, but I think I'm showing them again because they highlight disparities. In San Francisco, when we looked at a period estimate using all our data from 2004 to 2008, a snapshot of that time period, our average viral load in the city was 23,000. We had some disparities among people of color. Women only made up 6% of this data set, higher than the average San Francisco mean. IDU and men who have sex with men who are also IDU have higher viral loads. And of course, those who weren't on treatment and those who weren't engaged in care had an higher average viral load. So I think that the CVL marker is a biologic marker of disparity. I'm going to cite one of my favorite Haitian proverbs here, which is, the giving drugs without food is like washing your hands and drying them in the dirt. So we know that patient care is a lot more than just giving people medications. And the reason why our model in San Francisco is successful is that people make this decision with their primary care provider, with their social workers who screen them and support them with substance use referrals, mental health concerns. We have mental health and substance use people on site. There's support for getting housing, disability benefits, including ADAP enrollment. We have a pharmacist-led ART adherence program with one-on-one assessments of barriers, education, medicine reviews, ongoing monitoring. There are patient education programs and support groups. There's a linkage to care and retention support team that I referenced in my other slide. And all of this cannot be done without political will, because Healthy San Francisco covers all San Francisco residents, regardless of their federal documentation status. We need to address people's comorbidities. A lot of my patients in my primary care clinic, the HIV is the least of their problems. I'm working with their diabetes. I'm trying to get people to stop smoking. I'm trying to get people to exercise more and wear a seatbelt and a helmet when they bike. Like, I'm doing primary care. And we need to make sure, I'm working with them on their depression and substance use issues, et cetera. So those things need to be addressed. We can't be just giving people ART in a vacuum. And we have to think about the priorities for people. People who are HIV positive have a lot of things on their mind, and they may not be antiretroviral therapy. And we need to make sure that we're meeting our patients where they're at and making sure that their issues and what they think is most important is being addressed, because that's how we can help move people along from pre-contemplation to contemplation to action on initiating antiretroviral therapy.